nicely relaxing.
Yeah, yeah, yeah.
Huh? The lucky fellow, Tiwari. Anil Tiwari.
He's enjoying.
Enjoying it. Only except speaker, anybody can enjoy, you know. Where is the speaker today? Sri Krishna is there, huh?
Sir, ma'am joined. Some technical issues. Is again logging in.
Hello. Can you hear me?
Yeah, ma'am. Now you are audible, ma'am.
Yeah. Okay. Fine. Let me know when to start.
Yeah, ma'am. Can you share once your screen, or shall we start off RSV?
Just let the screen share so that you can do it again when the time comes.
Yeah.
Had a lunch?
No, it says host disabled screen sharing.
Yeah, that's the setting I need to enable. Try it out now. It should work.
Yeah.
Nagmani madam, you had lunch?
Yeah.
Because you know, in this CME program, no lunch, nothing will be given.
I'm actually doubting whether people will attend also, because everybody's got so bored of the CMEs. Yeah.
No, ma'am. See this. Before starting only, we have 27 participants. So more yet to join. Yeah.
The speaker.
So can you see my screen?
Yes, ma'am. Yes.
Yeah.
Yes, ma'am. Yeah.
Dr. Tanu, you can stop sharing screen, and I'll hand over the host to Pawan, and we are all set to start. PATS Telangana kada Pawan, nuvu?
Yes.
Yeah, I'm making you the host. Good luck.
Yeah. Thank you, RSV. A warm welcome to all the delegates, all the participants from Pediatric Academy of Telangana State. A warm welcome to you all. As a crusade against antibiotic resistance, Pediatric Academy of Telangana State has started this initiative called RAP-STAR. RAP means it is Rational Antibiotic Prescriber. So just to sensitize all the pediatricians, this program has been taken by our dear President, Dr. M. Surendranath sir, as a Presidential Action Plan 2021. So we are going to have these sessions entire year, every second Sunday of every month. So first Sunday we have Dr. Suhas Prabhu. So he is our guest, and the second session last month, Dr. Bhaskar Shinoy has took a session on respiratory infections, antibiotic practice in respiratory infections, and Dr. Suhas Prabhu sir took on culture or no culture, be rational. So that was the topic he took. And today we are very fortunate to have Dr. Tanu Singhal, who is infectious diseases he is a consultant at Kokilaben, Mumbai. So after that, we are going to have a quiz from the talk itself. We have some exciting prizes, each prize worth 500 rupees, which is delivered to your home. This is from a PATS initiative. So delegates have a chance to win 500 rupees worth prizes as a best delegate of the month certificate, and also some gifts from the PATS. And followed by, we will have a role play by Dr. S. Sri Krishna, who is the head of the Department of Apollo. And after that, question and answer session. So with that, I welcome our President, Pediatric Academy of Telangana State, Dr. Surendranath sir, to give a talk.
Yeah, good afternoon, dear friends and members of Pediatric Academy of Telangana State. Today CME, I invite Dr. Tanu Singhal, who is a very well-known infectious disease specialist from Mumbai. Madam is a consultant for infectious diseases at Kokilaben Hospital, who is very well known for her talks about the rational antibiotic practice, in fact. And we also welcome Dr. Ravi Kumar, who is the Vice President of Central Zone, and Dr. Arjun, who is the President of Twin Cities Branch, and Dr. Sri Krishna, who is the Secretary of Twin Cities Branch IAP, and all the Pediatric Academy of Telangana members for today's RAP-STAR program. So the program, in fact, we have planned every second Sunday at 3 p.m. post-lunch session to make the people aware of using the antibiotic rationally. So this is the third in series. Today, Madam is going to discuss about the antibiotic usage in the intensive care units. I request Dr. Sri Krishna, kindly take over and continue
Sir,
the proceedings.
yeah,
And today's chairperson, I invite Dr. Nagamani Madam, who is the AP member from Khammam, and she is the office bearer. She is the representative of the Khammam from the PATS Telangana. I request the madam and
Sir,
Pawan to introduce
sir,
the speaker.
before
for
handing
today's
over to Nagamani ma'am, the moderator of the today's session, I request Dr. Ravi Kumar sir, the Vice President of Central IAP, to say a few words.
Yeah, good evening. Thanks for giving the opportunity. Antibiotic, whatever, how much you want to avoid with a vaccine, it is just not possible. So it is a mandatory after the Pennsylvania's Alexander Fleming detected. So you are forced to use antibiotic day in and out. So you are trying to prevent one-side infection. So, but how many times you read also, still you have a lot of confusion. I am damn sure Dr. Tanu Singhal is going to give a crystal clear clarity, and all the questions and queries will be just clear after her talk. So I wish all the best, and I wish Dr. Tanu Singhal madam also. So all the best for a good number of audience are there, and you know Telangana and TCB, they really appreciate the academics. This is the third in the serial, you know.
Yes,
Nagamani
sir.
madam, not that serial. So this is a different serial. Third in the serial. So the serial is going on third part. So your attention to RSV, Bhavan and Tanu madam. Thank you.
That's our Vice President Ravi Kumar sir. Now I request Dr. Narayan Reddy sir, Dr. Narhari sir, Dr. Yashwant Rao sir, who has accepted our invitation and joined today's session. The Central IAP members, to all the Central IAP members. Sir, Dr. Narayan Reddy sir, few words from you.
Yeah. Good afternoon, everybody. It is a need of the hour. Rational antibiotic use need of the hour now because drug resistance is increasing. Future after 5-10 years, if you don't use rational antibiotic, after 5-10 years, you may not have antibiotic to treat the common infection also. That's why. So unnecessary viral infections should not be used antibiotic, watery diarrhea, running nose. So better to avoid unnecessary antibiotic. So rational antibiotic need of the hour. It is essential now. All practitioners should be sensitized of these rational antibiotic. That is a RAP star, but a rational antibiotic prescriber is very important. It's a good initiative by Surendanath and Pawan. PATS is using to sensitize all pediatricians of Telangana, and not only Telangana, all over India. That's very important. Thank you. All the best.
Thank you, Narayan sir. Dr. Yashwant Rao sir.
Good evening, everybody. I thank PATS team 2021 for having initiated a dream project of Surendranath sir. Surendranath sir has been at the forefront of avoiding antibiotics right since 2014. It is the third in the series. We had Dr. Bhaskar Shinai last time. We all know that it takes at least 40 to 50 years for the new antibiotic to set in. We have been seeing in the war module our speakers saying sensitizing us how many years it takes, how many years an antibiotic develops. So the need of the hour is effectively used wherever we need antibiotic should be used, sensitized everybody once and all. And we have Tanu Singhal madam, who is an ID specialist, who will be addressing us and sensitizing us on use of antibiotics in ICU. So thank you once again, PATS team, for bringing in speaker and sensitizing us.
Thank you, Yashwant Rao sir. Dr. Narhari sir.
Can you hear me?
Yes, sir. Very much.
Good afternoon, everybody. So this is a good initiative taken by PATS Telangana. Really appreciate your efforts. And antibiotics are really a good weapons in our armamentarium of defense. So let us spare our antibiotics because day by day infections are increasing, but antibiotics are not coming. There are very few in pipeline. So better to spare and reserve some of the antibiotics. We should not abuse the antibiotics. So let us start the sessions, and thank you.
Yeah, thank you, sir. Dr. Arjun sir, the president of IAP TCB. Dr. Arjun sir, are you there? Yeah. So now I think Dr. P.V. Srinivas Rao will give vote of thanks at the end. I request Dr. Tanu Singhal madam to, I request Dr. Nagamani ma'am to introduce the speaker and start the session. After this scintillating talk, we'll be having an exciting quiz with prizes worth, each question worth 500 rupees. So 5 questions will be there. So after that, a nice role play by Dr. Sri Krishna sir. Sir has also joined. This is on leaky gut. How to avoid antibiotics in leaky gut. Over to you, Nagamani ma'am.
Yeah, I welcome you all today's webinar, all my colleagues and my friend Ravi Kumar. And I'm happy to introduce young dynamic Dr. Tanu Singhal. I heard her exactly a year ago about tuberculosis. Question session was never ever ending that time. And as you know, Tanu Singhal, she did her post-graduation from All India Institute of Medical Sciences, Delhi, prestigious institute. And she did her post-graduation in infectious disease from London School of Hygiene. And presently she is working as a consultant at Kotlaband Dhirubhai Ambani Hospital, Mumbai. With this, I welcome you, Tanu. Just over to you.
Hello.
Yeah, we can hear
Yes.
you.
Yes. So I would really like to thank IAP Telangana for inviting me for this talk. And I hope you have some take-home messages at the end. So with that, I'm going to share my screen. Yes. So can you see my screen now?
Yeah.
Yeah. Okay. So with that, so basically, you know, antibiotic use in the PICU is really challenging because in the intensive care unit, we are dealing with serious and life-threatening infections. Many of them are community acquired, or some of them are even nosocomial. And here we have to get the empirical therapy right, as you don't have time to upgrade. Vis-a-vis a patient who comes to you in the OPD and you start an antibiotic, and if he's not better in 2 days, you upgrade. Here you don't have the chance because 2 days later the child may be no more. And at the same time, you have to implement antimicrobial stewardship to prevent resistance. So you have to get the patient better and you don't have to overuse antibiotics. So that means you don't underuse and you don't overuse, and you have to get it right. So it's often a catch-22 situation. So before we go to discussing specific cases, let us talk about the basic principles. So the first question to ask ourselves is that whether an antimicrobial is needed indeed. And we must remember that there can be other causes of fever. In the PICU, you may have central fever, you may have drug fever, you can have fever due to atelectasis, you may have post-surgery fever, which may not need antibiotics. At the same time, you have many patients who have lines and tubes and catheters, and when you send cultures from these, you grow some organisms. That may merely mean colonization. So that does not merit antibiotic therapy. But let us say that, yes, you do feel that you need an antibiotic. You have to decide again on the basis of what is the likely organism based on the clinical syndrome that you're dealing with. So for example, if you have a child with pneumonia, you know you have to cover pneumococcus, maybe mycoplasma, etc. Then you also have to think what is the likely antimicrobial resistance in that patient based on the local epidemiology and also the previous antibiotics received. So for example, if the patient in the ICU is already on ceftriaxone and the patient gets a new infection, you know ceftriaxone is not going to work. Or if you have a patient who gets an infection in your ICU and you have a lot of MRSA in the ICU, you may have to use MRSA cover empirically. And also it depends on what is the site of infection, what are the host comorbidities. So for example, if the patient has a CNS infection, you have to use an antibiotic which goes into the CNS. If the patient has renal dysfunction, you don't want to use antibiotics like aminoglycosides, which can worsen it. So all these factors determine your therapy. Then once you choose the antibiotic, you have to be very clear about giving the correct dose. And many of the antibiotics need a loading dose, and you have to give it. May I ask the audience to mute, please? And then if the patient needs a source control, you have to go ahead and do source control, because sometimes if you have an infection or an abscess, until you clear that infection, you will not get better. And then your task is not over, because at 48 hours, based on the culture reports, based on the response to treatment, you may decide you have to optimize therapy. You have to either escalate if the patient is not improving, or you have to de-escalate, and you have to look at the culture results also very carefully and interpret them properly. And you also correct the dose, because many times we start the antibiotic, the patient has renal dysfunction, and then later on, when the renal dysfunction improves, we don't remember to correct the dose, and you give it for the shortest recommended duration. So briefly, these are the various principles on the basis of which you use antibiotics in intensive care. And we are going to discuss some of these principles through illustrative cases, where we will talk about both community acquired and nosocomial infections. And we will also talk about both empiric and definitive therapy. So let us come and, I'm going to show these cases, and there is no option of you writing the answer in the chat box. But I want you to think in your mind when I show the options as to what antibiotic you would have given, and then we will discuss the answer. So let us say you have this 8-year-old male, previously healthy, with high fever and headache of 2 days duration. He has neck stiffness. The GCS is 15/15. So you do a CBC, you send a blood culture, and you do a lumbar puncture, and you are waiting for your results to come. So before and you want to give your first dose of the antibiotic, because if it's meningitis, then the antibiotic should go in as soon as possible. So what empiric therapy are you going to give awaiting the results? Will you give ceftriaxone? Will you give ceftriaxone and vancomycin? Or will you give ceftriaxone and acyclovir? And I want you to think in your mind, what would you have chosen if you had such a patient? Can I ask the people to please mute themselves? The audience? Okay. So now, basically here, actually the correct answer is ceftriaxone, because people may think that if it's bacterial meningitis, then in the current day and age, you would want to give ceftriaxone and vancomycin. But that is provided your CSF result comes back and you know that this is bacterial meningitis, because this may also be a case of aseptic meningitis or viral meningitis. So the first dose which you give can be ceftriaxone alone. And if your CSF comes back like bacterial meningitis, then you add vancomycin till your culture reports come back, because you want to cover drug-resistant pneumococcus. Now, what about using ceftriaxone and acyclovir? Because this is like an acute febrile encephalopathy. But if you look at this patient has a meningitic presentation. The patient doesn't have an encephalitic presentation. So you don't really need to use acyclovir here. That would be relevant if you had a patient who would have come with fever and altered sensorium. So this patient, we continue. The count is 8,000. They are 60% polys. The CRP is 10 milligram per liter. So it's basically normal. The CSF shows 1,000 cells, 70% polys. Sugar is 67/85.
Tanu ma'am,
Yes.
1 second. I am muting all. Only you can unmute and speak, ma'am. Others
Okay.
can't do that. Yeah.
Okay. So, so if you look at the sugar is normal, the protein is 30 milligram%, which is normal again, and the gram stain is negative. So when you look at this picture, it looks more like aseptic meningitis. However, you're worried about the 70% polys. So the next question which I have is that what will you do with this report? Will you stop the ceftriaxone right away? Will you stop it after 48 hours once your aerobic culture comes negative? Or you, to be on the safe side, you would give ceftriaxone for 7 days? Or would you request for a multiplex PCR in the CSF if available? So let us think in your mind what you would do in this situation. But I want to discuss the answers. Now, stopping ceftriaxone right away seems a little difficult because the cells are high, there are polys there, though the protein and sugar is negative, and in bacterial meningitis, one of these should have been abnormal. Another option is to stop after 48 hours once cultures are negative, but remember that in bacterial meningitis, the cultures may be negative 50% of the times. Giving ceftriaxone for 7 days doesn't seem to be a good idea, because it will mean that the patient will remain hospitalized, and this may all be a viral meningitis. So if you have the facility and if you have the logistics, you can actually do a multiplex PCR in the CSF, and because that may give you an alternative diagnosis. And if in this case, however, the multiplex PCR came positive for enterococcus, so you know that this is enterococcal meningitis. There's no doubt about the diagnosis. Antibiotics are stopped and the patient is discharged after 48 hours. So there may be people in the audience who may say that what this multiplex PCR costs 10,000 rupees. Why do it? But remember that by doing this test, you have made a definitive diagnosis, and actually, if you have discharged the patient early, you have kind of saved on the cost of so many other tests which you would do, or antibiotics that you would give, and hospital beds which would be occupied. So remember that rational antimicrobial therapy also involves a good investigative approach, because sometimes you can't practice rational therapy unless you have the support of investigations. Of course, if the patient is not affording this PCR and if it is not available, then maybe most of us would actually stop antibiotics after 48 hours if the cultures come negative, because it looks more like a aseptic meningitis on the CSF. Now let us come to the second case. This is a 1-year-old who has fever, cough, and breathing difficulty for 2 days. At admission, the baby has tachypnea. The saturation is 92. There is reduced air entry on the right side. The TLC is 19,000. A blood culture is sent. And of course, now this is a SARI, so a COVID RT-PCR would be done, which is negative. And if you look at the X-ray shows that there is a large complete opacification of the right hemithorax, which would mean that you can't really see any air bronchograms, but it could be a consolidation with an effusion. So now the question would be that in this situation, what empiric therapy are you going to give? Of course, you will do an ultrasound to check if there is pleural fluid, and you will do a tap and all, and you will wait for your blood culture reports. But would you give ceftriaxone alone? Would you give ceftriaxone and linezolid? Would you use ceftriaxone and azithromycin? Or because the child is very sick, you will give piperacillin, tazobactam, and amikacin? Now, if you look at this patient with this kind of pneumonia, the most likely organisms are pneumococcus and maybe Staph aureus. At this age, mycoplasma is unlikely, and also gram-negative organisms are unlikely. So therefore, there is no logic of using azithromycin or using drugs like piptase and amikacin. Now, the main question would be whether you just use a cover for pneumococcus, or would you like to use a cover for pneumococcus and MRSA? That is the main dilemma which many people would have in this situation. And again, linezolid is not a good drug to give for empiric therapy. Of course, this patient does not mimic TB, but there can be pneumonia, TB presenting as pneumonia, where you wouldn't want to use linezolid. So maybe you could have an option of ceftriaxone and vancomycin. But remember, most of the studies have shown that most of the pneumonia with effusion is actually pneumococcus. So it would be okay to give ceftriaxone because this patient is really not having any markers for a MRSA. However, it would be in some cases, if the patient is really looking sick and toxic, then you may use ceftriaxone and vancomycin also as empiric therapy here. And of course, you would wait for your blood cultures, and if there is pleural fluid, you would definitely tap it to see whether it's an effusion or an empyema, and it might give you the etiologic diagnosis. So remember, in case of pneumonia, your initial empiric therapy depends on the age and severity. And in a young child, you usually want to cover pneumococcus, and in an older child, you want to cover pneumococcus and mycoplasma. Now let us come to another case, like a two-year-old who has grade 3 VUR bilateral. The baby is on cotrimoxazole prophylaxis. He had a breakthrough UTI, which was treated with cefexime 3 months ago. Now he has fever. And when he comes into the hospital, he's sick, he's toxic, they have poor peripheral pulses, and he's admitted as a case of urosepsis with septic shock. And because that is the most likely diagnosis because of the prior history of VUR, prior history of UTI, of course, you will do a CBC, you will do a urine routine and everything else, and you will, of course, send cultures. So now my question here is that in this patient, what empiric therapy are you going to choose? I haven't kept an option of ceftriaxone alone because, here in this very sick patient who has already received cefixime in the past, there is a risk of a ESBL organism. So whether you would choose ceftriaxone and amikacin, whether you would give piperacillin tazobactam, or would you give meropenem, or are there people who would want to choose meropenem and amikacin? So you could think of the answers in your head, but let us discuss what should be the right answer. So this is a patient who is sick and toxic. So your empiric therapy should be right. And there is a high probability that you can have an ESBL infection in this patient. So therefore, ceftriaxone alone is not a good choice. So now this patient already has renal compromise because of VUR. And amikacin, most of us would like to avoid in this situation because it can further damage the kidneys. So I would not use it as first choice. Now the options remain between 2, 3, and 4. So this is a very sick child with a possible ESBL infection where the inoculum could be high. And we know in such situations, for ESBL infections, carbapenems are better than BL-BLI combinations. Now, if this same patient had just come with fever and was not in septic shock, you could have gone ahead and used piperacillin tazobactam. But if this child is in septic shock, it's better to use a carbapenem. And when you are using a carbapenem, adding aminoglycoside to the carbapenem does not make any sense. So you would not choose option 4. So I think in this, the right option would be to use a carbapenem upfront because this patient is really sick. Now, let us say after some time, IV meropenem is started. 48 hours later, urine and blood cultures grow. And what surprisingly, you get a non-ESBL E. coli sensitive to amoxicillin and ceftriaxone, and the patient is better. So sometimes people ask this question that the patient was so sick, how did we get such a sensitive organism? And we must remember that it is the sensitive organisms which are sometimes the most virulent vis-a-vis resistant organisms because they are not carrying the burden of drug-resistant plasmids with them. Now the question is, as a part of optimization of therapy or de-escalation, what are you going to change to? Will you change to ceftriaxone? Will you change to ampicillin? Or will you go down to piperacillin tazobactam? Or are there other people who would want to continue meropenem? So this is a very important principle of antibiotic stewardship, that you may have started with a high-level antibiotic in very distressing circumstances, but once you get the cultures, you have the responsibility to de-escalate. So therefore, continuing meropenem or downgrading to piperacillin tazobactam is not recommended. Now, the next is, what would you choose between ceftriaxone and ampicillin? So here, which is the narrowest spectrum drug? The narrowest spectrum drug is actually ampicillin. So ideally speaking, this patient should be put on ampicillin. And once the patient is ready to go home, the patient should be given oral amoxicillin and not oral cefixime or anything, because you have an opportunity to use a very narrow spectrum drug. So remember that when you are choosing the antibiotic for de-escalation, you should actually go to the lowest level. And ampicillin works very well in urinary tract infection. It is highly concentrated in the urine, and its levels are very good. So actually, you would be changing to ampicillin. So that is an important principle which this case highlights, that you have to think of what could be the pathogen and resistance pattern, look at the severity of illness, look at the underlying comorbidities, change the antibiotic, and start a good antibiotic and then de-escalate. Now, let us say in this patient, the commonest question would be that, after starting the antibiotic, it basically grows an ESBL E. coli, and that ESBL E. coli is not sensitive to any oral drug. The only drug it is sensitive to is nitrofurantoin, and all the others are injectable. So 3-4 days later, when this child is ready to go home, the question would be, what are you going to use? So you can't use nitrofurantoin because it doesn't work for tissue infection. So you have to choose either between an aminoglycoside, or you have to continue with maybe cefoperazone sulbactam, which can be given twice a day. Even ertapenem in children can be given only twice, has to be given twice a day and not once a day like in adults. So here, it all depends on the family circumstances. If this was a patient I was seeing, I would send them back on twice a day BL-BLI combination or ertapenem therapy and not use an aminoglycoside. just for convenience sake, because this patient needs to have his kidneys protected. However, there would be other people who would send the child home on once a day intramuscular aminoglycoside if the parents are not affording and if they don't have the facility to give parenteral therapy. Now let us come to the next case. This is a 5-year-old who has fever, abdominal pain and vomiting. And initially, when you have a child presenting like this, many people don't examine the child, think that this is acute gastroenteritis and start oral cefixime, whereas what is actually needed in these patients for somebody to palpate the abdomen and just pick up if there's any tenderness. So there is a sudden increase in pain and the child is admitted with abdominal guarding and rigidity, and ultrasound shows a perforated appendix, and this child has to be taken up for an urgent laparotomy, and this child is not in septic shock. Now, the next question is that what empiric therapy are you going to start in this patient? Will you start piptazo? Will you start piptazo with metronidazole? Or will you give ceftriaxone and metronidazole? Or will you give coamoxiclav and amikacin? So let us rationally think of the choices. Now here is a patient where you want to cover E. coli and anaerobes. And with the current data you have, there is a high prevalence of ESBL in E. coli. And this is a sick patient. Now, had this patient come with just a appendicular pain, and there was just an inflamed appendix, but there was no evidence of perforation or a periappendicular abscess, ceftriaxone and metronidazole would have been a good choice because you don't really need to go to high-level antibiotics. The problem with coamoxiclav and amikacin is that coamoxiclav does not cover the bacteroides, which causes these intra-abdominal sepsis. So coamoxiclav is a good antibiotic for anaerobic infection above the diaphragm, but not for below the diaphragm. So when you use this combination, you are not covering your anaerobes well. Then, so that leaves you with these two choices. Now, when you use piperacillin tazobactam, you cover the abdominal anaerobes well. So you don't have to combine metronidazole. So you could actually, in this patient who is slightly sick, you could use piperacillin tazobactam here. Some people, if the patient was not having a perforated appendix or they know that they're going to do source control, even ceftriaxone and metronidazole would have been a good choice. You could also use coamoxiclav and metronidazole in this situation. But this is a patient where you really don't need to use meropenem like the previous case because that child was in septic shock. So piptazo was started, the patient was operated, intra-pus cultures came sterile. So the next question is, how long will you continue antibiotics? Are you going to give antibiotics for 5 to 7 days? Will you give it for 7 to 10 days? Or will you give it for 10 to 14 days? So remember that nowadays, the duration of treatment for all infections is reducing. So you just need to give short therapy because you've already done source control. So 5 days of therapy or maximum 7 days is essential, is okay. In a patient who comes to you with just an inflamed appendix, you don't need to give antibiotics for more than 24 hours. So one important aspect of rational antibiotic therapy is also to concentrate on the duration of treatment. And actually, in the current day and age, apart from conditions like neonatal sepsis or meningitis or infective endocarditis, 7 to 10 days or 5 to 10 days of antibiotics is more than enough. Now, let us come to a different site of infection, which may again, get admitted into your intensive care unit, like a 6-year-old with chicken pox. Day 7, the child comes with high fever, severe pain in the limb, and septic shock. So here you are thinking of whether this could be, this is looking like necrotizing fasciitis and not cellulitis. So in this situation, what therapy would you want to use here? And you have various options like ceftriaxone and clinda, piptaz clinda, ceftriaxone and linezolid, or ceftriaxone and vancomycin and clindamycin. So again, you have to think through what are the pathogens. So your main pathogen here is group A beta hemolytic strep. That causes most of the infections in these patients. So, and you know that this is a toxic shock syndrome-like situation. So you need a protein synthesis inhibitor. So you would give ceftriaxone and clindamycin. Piptaz and clindamycin is not needed because in this case, gram-negative organisms are not there in the reckoning. As far as ceftriaxone and linezolid is concerned, the advantage of this is that you are covering MRSA also, and linezolid also acts as a protein synthesis inhibitor. But I mean, why use linezolid when it is not needed? Also, if the patient is bacteremic, linezolid may not be a good drug. And ceftriaxone and vancomycin and clindamycin is also another option which you may want to use if you have like a purulent skin and soft tissue infection, like you have pus pouring out, because in that case, staph aureus may be a possibility and you want to cover MRSA because this patient is very sick. So the bottom line is that for such a patient, you need to cover definitely group A beta hemolytic strep. You definitely need to give a antitoxin drug, and plus minus you may want to cover MRSA. So you can choose either between option 1 and option 4. And the other important thing is that surgical debridement is crucial along with optimal antibiotic therapy. And as I've already discussed, that in some patients you may want to cover for MRSA also in the onset. And also in these patients, what happens is if you have pus and you send it for culture, even if you have started an anti-MRSA antibiotic, after 48 hours, you will get the culture report and you will be able to optimize therapy and de-escalate. And therefore, your anti-MRSA antibiotic will not continue for a long time. Now, let us look at another case, which is a patient who has history of fever and right thigh pain for 2 days. MRI is suggestive of osteomyelitis of the femur. The right leg is swollen and an ultrasound Doppler shows that there is deep venous thrombosis. So blood culture is sent. So now the question here is, in this patient who has severe osteomyelitis and deep vein thrombosis, what antibiotic will you start? Will you start cefazolin, or cloxacillin, or vancomycin, or clox and vanco? Now in this patient, your main culprit is staph aureus, and there it could be also MRSA because you're finding deep vein thrombosis, and it is known that MRSA infections increase the risk of necrotizing infection and DVT. So this patient, you have to be aggressive with treatment, and you would start clox and vanco because it would cover MSSA and MRSA. Vanco alone is not a good drug because it doesn't cover MSSA well. And cefazolin, cefcloxacillin, though good for MSSA, don't cover MRSA. So in this patient, you probably would like to use clox and vanco here. And then after your cultures and all come back, you can de-escalate. If it is MSSA, you continue with cloxacillin. And if it's MRSA, you continue with vancomycin. Or later, you can even give teicoplanin. Now we will come to some cases of hospital-acquired infections. So you have a 10-year-old child with dengue fever. He's admitted on day 6 of illness with severe dengue and shock. And this patient is on oxygen. There is a central line and arterial line. You are resuscitating the patient with IV fluids and inotropes. So the question is, which antibiotic will you give in this patient? Will you give ceftriaxone or piperacillin-tazobactam, meropenem, or none? So this is a patient who has dengue shock syndrome, and there is really no data to support that at the time when they come in, they have a bacterial co-infection. So you would actually not want to give any antibiotic in this patient, because sometimes the ICU people say, oh, we are putting lines in. But remember that antibiotics don't have any preventive value. So it's not that by giving antibiotics, you will prevent an infection. The only thing which you will do is that you will make the patient susceptible to a resistant infection. However, in this patient, as it happens in many ICUs, piperacillin-tazobactam is started. The patient recovers. Antibiotics are stopped after 5 days. Day 6, the fever returns. The patient still has a central line. The counts and CRP go up, and the child is in early septic shock, which is evidenced by tachycardia and a wide pulse pressure. So now, here the question would be, the CLABSI is suspected, and paired cultures are sent. And here now you have to, while the child didn't need antibiotics when the child first came in, now the child needs antibiotics. So what empiric therapy are you going to start? Are you going to go to meropenem, or will you go to meropenem and colistin? Will you give meropenem and fluconazole, or it depends on the ICU local epidemiology? And it actually depends on the ICU local epidemiology. But in this situation, in most ICUs, people would give a colistin-based therapy, because if the child is already on Piptaz, your meropenem is unlikely to work. And we should understand that rational antibiotic therapy is also not underusing antibiotics, because if in this patient, somebody just escalates to meropenem, they are making a mistake, because that will not cover the infection properly and the child will deteriorate. So you have to use the right antibiotic in these patients, even if it means that you're overusing antibiotics. So colistin and meropenem is started because in that ICU, you see carbapenem-resistant pathogens. 48 hours later, blood culture grows Klebsiella pneumoniae. The carbapenem MIC is more than 16. Colistin and fosfomycin are sensitive. Tigecycline is sensitive with an MIC of 2. The patient is better, though still febrile. The line has been removed. So now the question would come is, what would you change in treatment? Would you continue colistin and meropenem? Would you change to colistin and fosfomycin? Will you give to colistin and tigecycline or colistin and tigecycline and fosfomycin? So here you're dealing with a carbapenem resistant infection where the carbapenem MICs are more than 16. So meropenem has no role to play. So, and we know that for sick patients with carbapenem resistant infections, it is better to use combination therapy. So what second drug would you use? You would use fosfomycin because that has good intravascular levels. And tigecycline does not go into the bloodstream well, so it's not a good drug for bloodstream infection. Also, the MIC is 2, which is high. Therefore, you would give colistin and fosfomycin here. So again, this case tells you that in a patient who has a carbapenem resistant infection, you need to use antibiotics properly and you have to treat these patients appropriately. Otherwise, 50% of these patients might die. Coming to another case, like this is a girl who has Fulminant-Guillain-Barré syndrome. She's ventilated, she has central lines, she's on IVIG, steroids, plasmapheresis, antibiotics, and she gets a new onset fever that does not respond to paracetamol. And as screen for infection, all cultures are sent. Blood cultures and all are negative, but the urine culture grows candida, that is fluconazole sensitive. So now the question is, what will you do? Will you start an antifungal here? Or will you not give any antifungal? Because we know that in a patient who has been admitted in the ICU for a long time, your candida in the urine may just be a colonization. It may not be true infection. But in this patient who is immunocompromised, immunosuppressed, they are at risk for invasive candidiasis, and it's possible that the candida in the urine is a marker of invasive candidiasis, and blood cultures are often negative. So it would be worthwhile to actually start with an antifungal. However, what is not fitting in with an infectious fever in this patient is the fact that the fever is not responding to paracetamol, which would make you think whether this patient has fever due to autonomic dysfunction, which often happens in Guillain-Barré patients. So you start IV fluconazole, but 48 hours later, there's no improvement in fever. So what will you do? Will you stop fluconazole or will you escalate to amphotericin B or an echinocandin? So here, if the patient is not responding and the fever does not have characteristics of an infective fever, it would be better to stop the antifungal and try and see what other things are there. And later on in this patient, it turned out to be a fever of central origin because of autonomic dysfunction. And then the last case. This is a 3-year-old who's ventilated for influenza pneumonia. Day 10 of ventilation. Weaning is not possible. So the tracheal cultures are sent, which show Pseudomonas aeruginosa. But the baby doesn't have fever, the baby's counts are normal, and the X-ray does not show any new infiltrate. So what will you do for this tracheal culture positive? Will you start inhaled tobramycin? Will you start IV meropenem, or will you do nothing? So the answer is you will do nothing, because in this patient, this is just colonization. So just a culture being positive does not mean you have to give antibiotics to the patient. So that is in all, I wanted to talk to you about some of the cases which come to the intensive care unit and how you need to treat them. You have to be careful. You need to get it right the first time. And so even if you have to think logically about what the pathogen is, what is the resistance pattern, and give the antibiotic. Pay attention to source control, because especially if you are having a intra-abdominal infection, try and see how you can get rid of the infection. If your patient has a central line, think of, you may want to get rid of the central line, and then de-escalate whenever possible. So after your cultures come back, always de-escalate, never continue the high-end antibiotic, because some of these patients will be in the ICU for a long time, and at that point in time, they may need all these antibiotics. So always try and conserve whenever possible, reduce duration of therapy to the minimum possible. In fact, nowadays, some people use a ProCal-based tool to reduce therapy duration. That means if your procalcitonin comes down to below to 10% of the peak, 20% of the peak level, you can stop treatment. So you can even think of, when you're giving heavy duty antibiotics like colistin, fosfomycin, tigecycline, you can actually stop treatment in 5 to 7 days if the patient is better, and you don't really need to give 10 to 14 days of therapy. avoid treating colonization, and don't use antibiotics as prevention. Like that in that patient with dengue fever, don't give antibiotics just because you're putting a line in. And finally, one more point which I didn't put in the table is always use investigations. Logically, because investing in investigations is actually cost effective in the long run. While initially it may seem expensive, but later on you will find that the cost of the investigation is often offset by the cost of the antibiotics and the duration of stay in the hospital. So for rational antimicrobial therapy, you also actually need to have a rational investigation approach. Thank you.
Thank you, madam. Excellent presentation of case-based discussion of using antibiotics in ICU. Thank you very much. I request Pawan kindly take over and conduct the proceedings.
Yeah, Nagamani ma'am, any questions from the chat box? Would you like to say?
Yeah, about colonization with Pseudomonas in tracheal after prolonged ventilation. Is there chances of bacterial tracheitis, madam?
Yeah, there is a chance, and some people say that the bacterial tracheitis is a a precursor to VAP. But in that case, you generally have purulent secretions, plenty of secretions. You may have mild elevation of white cell count. So if you have that situation, then you can use inhaled antibiotics, not routinely.
Okay, thank you, ma'am. So, is there something like bundles in PICU protocols or something? What do you mean by that, madam?
Sorry, what?
Bundles. I mean,
Yeah. So there are bundles, like for example, you have a bundle for prevention. The prevention bundles are there, and you also have bundles for treatment. And that those bundles include these things. That one is send cultures. Second is choose the right empiric antibiotic, give the right dose, do source control, and then do optimization of therapy. And finally, give the correct duration of therapy. So that is actually a kind of bundle which you can use for treatment. So apply this bundle to every patient that you have in your PICU.
And one question, madam. De-escalation is always viewed as you don't know whether patient may go again go back to the old situation. So how do you de-escalate the patient?
So you have to take that brave step, because but if you are right in your principles, if your microbiology reports are reliable, if they correlate with the clinical situation, you should go about it. And there are so many studies or randomized control trials which have shown that after de-escalation you don't have adverse outcomes. So you have to do it because you have to conserve antibiotics for the same patient and other people. See, sometimes people have this fear that what will the parents say. So because you are discussing with them every day, so you have started meropenem, then after 2 days the report comes, and then the patient, you change the treatment, and then because these ICU patients are very fragile, they get bad again. So sometimes you feel that everybody will blame it on that step. So you have to keep the parents in confidence, and you have to keep telling them that this is what we are doing, and you keep a careful watch on these patients, because sometimes what happens is you de-escalate and then the patient worsens, and that may actually be due to a new infection that the patient has got, and it has nothing to do with the previous infection de-escalation being responsible.
Oh, okay. What is catch-22, madam?
Catch-22 is a word that if you do something and if you don't do something, both of them, both the options which you have in front of you are difficult to choose. So it's not, you can't choose easily. That's a catch-22.
Yes. That's a general phrase, ma'am. General phrase to say that you are in a catch-22 situation. Yeah.
Okay.
Lakshman Kumar sir, you want to ask something? Lakshman. Unmute Lakshman.
Sir, 1 second, sir. 1 second.
Yes, we can hear you.
Sir, Lakshman Kumar sir, you can unmute here.
Okay. Yeah, good evening, madam. Wonderful presentation. On behalf of Telangana, we would like to thank you for enlightening us the rational antibiotic in the NICU or PICU. The only question is our one case necrotizing fasciitis. The sick child is there, but cloxacillin alone is not available in the market. So in that situation, along with clindamycin, what would be the right choice to give it? Is it cefazolin or Amclox is available?
No, you could give cefazolin. You could also use cefuroxime if cefazolin is not available. You can even use ceftriaxone for that matter, because it's also good for skin and soft tissue infection. Amclox, the problem is that the ampicillin component won't work at all. I mean, so that is the issue with Amclox. And you have to give huge doses, because like if you have 250 mg of Amclox, it has 125 mg of cloxacillin. Amoxiclav may not be a good option, because amoxiclav, there is so much beta-lactamase being produced by that Staph aureus that it may not work. And amoxiclav has not really been studied well for Staph aureus. So you would choose one of the cephalosporins.
Thank you. Thank you.
What about the other derivatives of cloxacillin, madam? Sometimes other derivatives like
Yeah, you can use flucloxacillin. Fluclox is fine, because now some companies have started marketing, like Staphonex is available. These are available. The only issue with these preparations are the cost. So, it's like 1 gram is costing 800, 900 rupees. So if you have a big child, whereas cefazolin, 1 gram costs only 40 rupees. So if it's available, the other problem with cloxacillin is that, it can cause nephrotoxicity. So that's one more issue. You need to give it frequently, 6 hourly. Thrombophlebitis is there. So while cloxacillin is the gold standard for MSSA, there are some of the limitations, including costs, side effects, and adverse reactions.
Yeah, one more question, madam, for you, because in the periphery, majority of the practitioners are shifting from IV to IM. So in the ICU settings, so what are the rationale and the conditions, or what are the criteria should be there to shift from the intravenous to intramuscular injections or oral? How to then, what are the, any definitive criteria is there? Because a lot of misuse is there and a lot of problems are there.
So I would say that we can shift. I think rather than shifting from IV to IM, you should make an attempt to shift from IV to oral, if you have an oral option available.
Yeah.
Because now most studies say that unless you are dealing with a case like Staph aureus bacteremia, where you can't shift to oral, you have to give IV for 2 weeks, or you have meningitis or endocarditis. For other infections, there's enough data that once 48 to 72 hours have passed, the child's fever has gone down, the inflammatory markers have come down, and the child is accepting orally, and you have a drug which is orally bioavailable available, you can simply shift to oral. Like, people give IV ceftriaxone for enteric fever, and then they call the child for IV or IM ceftriaxone. That's not needed. They can shift to oral cefixime, which works as well. So if you're giving ceftriaxone for pneumonia, you don't need to change to IM ceftriaxone. You can either change to oral amoxicillin or oral amoxiclav or cefuroxime. The only role of giving IM therapy is if you have a patient where you don't have an oral option available and the child cannot stay in the hospital. So then you have an option of either sending the child with the IV line so that they can come back daily and you can give an IV injection to the child, or you shift to an intramuscular drug. But intramuscular injections are sometimes very painful because the volume is quite high. And if you don't give it properly, that itself can be a side. So, from my side, I often send the patient with a IV line, but we also should remember, the kind of place in which I work, we have all these facilities, whereas there are many people who are working in situations where, these facilities for, the family may not maintain the IV line well, and all those things are there. So there they may want to use an intramuscular injection. But
Okay, thank
generally
you.
speaking, most of the times you can switch to oral.
Thank you, madam.
Madam, some questions are there.
Yeah,
Can
yeah.
you read out?
Now, what is the sensitivity of multiplex PCR, madam?
So it is better than culture. That's all I can say. So yes, it is possible that if you have a partially treated meningitis, you do a multiplex PCR and you may draw a blank. But it is believed to be like the sensitivity of culture for for sensitive for non-treated meningitis is about 30 to 50%. In the multiplex PCR would be 70 to 90%. Because yes, some people may say that they've got this case of bacterial meningitis, they don't know what it is, and they ask for a multiplex PCR. So if you get an organism, then that cost is recovered, But if you don't get anything, then people think that the cost is it's the money is wasted, but that's not true, because you can clearly rule out some infections if you are PCR comes negative.
Yeah.
And another thing which people can do if they are in doubt about what the meningitis is due to is, after 2 or 3 days, repeat a CSF and see. Because if the first CSF, if it is done on the first day, does not give you an answer, after 2 or 3 days, you can do a CSF, and that might tell you clearly what you're dealing with.
Thank you. Any
The
question?
colonization, madam, tracheal aspirates colonization, always Pseudomonas is considered as a colonizer. What could be the reason? I mean, it is a silly question, but why Pseudomonas is always thought as a colonizer when you aspirate?
Because
tracheal?
one is property about Pseudomonas is that it needs least nutrition. So it can even grow in plain water. So that is why when a person, all these sites like surface of wounds, drains, trachea, it is common colonizer. So because just it has very low nutritional requirements. And second, it is most of the times resistant to the antibiotics which are commonly used for therapy, because Pseudomonas is resistant to comoxiclav, it's resistant to ceftriaxone, which are commonly used in treatment of most infections. So that is why it commonly comes in.
You cannot take it as a culprit for that, not improving the condition.
But yeah, you would take it as a culprit if there are other features to suggest an infection. So if the same patient whom you're getting Pseudomonas in the tracheal cultures has fever, has leukocytosis, has thick and purulent secretions, has increased oxygen requirements, and has a new infiltrate on the X-ray, then you would consider it that it is a pathogen and not a colonizer.
So, is there role of any antifungals in immunocompromised child in ICUs, madam?
Yes, so remember that when you have a child in the ICU who has a nosocomial infection, apart from thinking of gram-negative, gram-positive, you should also think of Candida. And especially if the child has been in the ICU for a long time, has a central line, has received steroids, has undergone any gut surgery, or has pancreatitis, is on dialysis, has received TPN. These are the situations which are risk factors for Candida. So if these patients are not improving with your antibiotics, which are properly chosen, then you should look for fungus and think about starting empirical antifungal therapy. But those risk factors should be there. So, if a child comes in with a pneumonia and has been there in the ICU for 3-4 days and doesn't have any of these risk factors, we should not think of Candida. And another thing is that many times you will grow Candida in the tracheal secretions, because it's common. Patient on antibiotics like Pseudomonas, you go Candida, that doesn't need treatment, because we know that Candida never causes a ventilator associated pneumonia. So you don't have to treat Candida in that setting.
So, for cystic fibrosis patients, any empirical therapy do you advise, madam? No.
So cystic fibrosis, the advantage is that you often know the pathogen, because these patients undergo repeated sputum cultures. So you sometimes know what the last, this was. What was the last treatment which was given? What was the last culture that? So then on that basis, you can use treatment. And this is a big problem, because earlier people were using ceftazidime and amikacin for cystic fibrosis patients. Then when resistance to ceftazidime came up, they were using meropenem. And now there is so much resistance to meropenem that they have to use colistin-based therapy. So always in cystic fibrosis, send your cultures and then modify treatment on that basis or on the previous culture report.
Thank you. So, any questions, Pawan?
Dr. Subramaniam sir is there.
Ma'am, I think, yeah. Any comments by Subramaniam sir?
Or Ravi Kumar?
It was a very good presentation by Madam Sir. Regarding empiric therapy, is there need for, can we make universal recommendations? Because the bacterial epidemiology keeps on changing from area to area. I think can we make universal recommendations based on that is one aspect. Another aspect is, can we make use of combinations in the empiric therapy itself? Why don't we go by monotherapy, which is of broad spectrum, and then decide the matters based on culture?
So combination therapy you would use if you are dealing with, with multiple organisms which you can't cover with one antibiotic. Like, so that is when you would use a combination therapy. Like I said, when you have a patient with osteomyelitis where you're thinking whether it could be MSSA or MRSA, you don't know. So then you use combination therapy. Because what drug would cover both MSSA and MRSA? Well, that's daptomycin, which we never generally don't use in clinical practice. So you would use combinations if one drug does not cover
both. Yeah.
both likely pathogens.
One comment, actually, you have given excellent guidelines, but all ICUs or that infection treating patients, they should have another buffer room that should be fumigated regularly, and the patient should be shifted. Again, the culture sensitivity done, because these guidelines everywhere, as it is, we cannot apply. Some areas, some organisms are very resistant to some antibiotic. Some organisms are taking very advantage. So each hospital should have its own culture sensitivity microbiology department very strong. So with your guidelines. So I hope this particular message, because even the smallest town like Nirmal and all, those places also, they are doing HEPA filters, they are using the HEPA filters, and they are trying to keep the treating area as sterile as operation theater. But still, the infection rate is slightly, we are not able to control, because this has to be done, culture sensitivity has to be done in each hospital. That's what I feel, Tanu madam.
Yeah. See, what I want to say is that there are two different things. One is infection control and the second is antimicrobial therapy. For infection control, you really don't need HEPA filters in most ICUs. What you need is actually good hand hygiene. You need good decontamination of the surfaces, cleaning, and you need to have good bundles for preventing CLABSI and VAP, etc.
Yeah.
HEPA filters are mainly needed if you're having a bone marrow transplant unit. So these are the things which are required for infection control. Routine fumigation is not recommended in ICUs any longer. We are not even fumigating OTs now. So what is important is surface cleaning, that, in your ICU, you have your HCAs who can do cleaning 3 times a day. They clean the high touch surfaces like the knobs, the computer keyboards, everything, and hand hygiene has to be adhered to. That is for infection control. And yes, for antibiotic therapy of nosocomial infections, every hospital should have its own susceptibility data. So based on which they know that if a child gets infection in a particular ICU, what empiric therapy they should start.
Yeah, very good.
One question is there. One question is there. Normally, madam, 2%.
I can't see that. What is that?
I'm saying, should all the broad spectrum antibiotics should be given in infusion only? 1%, madam.
Yes. So mostly antibiotics should never be given as a push. They should be given as an infusion over 30 minutes. However, some of the beta-lactams, like, for example, meropenem and piperacillin tazobactam, are better given as 3-hour infusion. So if you have basically high MICs, then you can, in your ICU, you can make a protocol that for antibiotics like piptaz and meropenem, imipenem, you can give it over 3 hours.
Okay.
Last question, madam. Is there any condition specifically which requires a loading dose of antibiotic in ICU?
Yes, so it depends on the antibiotic that you're using. So for antibiotics, some antibiotics which need loading doses are like colistin and polymyxin B, tigecycline, then also your your echinocandins like caspofungin or enidulafungin, and even vancomycin. Like in a patient who's critically sick with an MRSA infection, your first dose should be 30 mg per kg, not starting with 15 mg per kg. So the conditions where you give loading dose actually depends on the antibiotic which you use rather than the disease which you have. Yeah, in some situations, like what we do is, for example, a patient gets admitted in the evening and we want to give ceftriaxone. So I often actually give that patient 100 mg per kg right away. Instead of giving 50 mg per kg and then another 50 mg per kg in the night. So I give 100 mg per kg, and from the next day, we start as 50 mg per kg twice a day. So that is also a kind of
loading dose.
thing which you can do. And sometimes what I do in OPD practice is that if a patient comes to me in the evening and has a bacterial sinusitis or an otitis media or a pneumonia, and I'm prescribing amoxiclav or amoxicillin 30 to 50 mg per kg, then I ask them to give that 30 mg per kg dose in the evening itself. So that is also a type of loading dose only, but it is mainly, for logistic reasons, and also that you get a good level of the antibiotic in the blood. So those are also some times where you kind of give loading doses.
Thank you, madam. Thank you for the excellent presentation. Now I request Pawan to take us to the role play by our staff.
Sir, before the role play, there is an exciting quiz, sir. There are 5 questions which was given by ma'am from the talk itself. So the people who have attended the talk, they can easily answer. So each prize is 500 rupees worth, and there is a delegate of the month certificate will be given from Pediatric Academy of Telangana State. So I request all the delegates to rename your ID. Like I'm seeing iPhone, iPad like that. So it's very difficult to trace them. So this quiz is mainly for Pediatric Academy of Telangana State members only. So practitioners have more chances now to get prizes.
How many questions are there, Pawan?
Yeah, 5 questions are there, 5 answers. The first right answers will be given prize. So you need to change from everyone to my name. Please select Dr. Pawan there in the chat box instead of to everyone, so that it will come directly to me. So it will be easy for me to know who is the winner. So you need some more time to change your name. Yes, IAP membership is same as PATS. Yes, if you are a central IAP member, you are also the part of PATS. So once you are ready, I think maybe in 30 seconds, please rename your ID, and also I request you to put phone number also, so that we will call you. So after every question, there will be a 10 to 15 seconds time will be given. So you need to type in the chat box addressing me, Dr. Pawan, addressing Dr. Pawan in that. Are you ready? Yeah, this is an initiative by Team PATS 2021, supported by UVB Healthcare. The first question to all the participants. So this is from the madam's talk only. So you need to type the exact answer what ma'am told. Okay. So what is the empiric therapy of choice for bacterial meningitis in children today? Don't put answer in the direct for everyone. Please address to Dr. Pawan in the chat box. Only those things will be counted. So what is the empiric therapy of choice for bacterial meningitis in children today? Dr. Anjay sir, you want to ask anything regarding this? Yeah, time is up. The answer is ceftriaxone and vancomycin. Next question. What should be the empiric antibiotic for lobar pneumonia in a 1-year-old child? Your time starts now. Very nice to see all seniors participating. They're typing their answers. Very happy to see that. The gifts will be delivered to your own clinic or your home. So start answering, start answering. Yeah, I think you should stop. The right answer is ceftriaxone. Now the third question. What would you use for therapy for urosepsis and septic shock due to ESBL E. coli infection? Your time starts now. All 70 participants can try. Yeah, time's up. The answer is meropenem. Yeah, next question. How long would you give treatment for appendicitis with perforation? Your time starts now. This was specifically told by Dr. Tanu Singhal ma'am. All questions are from the talk itself. I'm very happy seeing all the participants chatting the right answers in their chat box. Yeah, time is up. It is 5 to 7 days. Now the last question, I guess. What antibiotic will you give for treatment of a positive endotracheal culture due to Pseudomonas aeruginosa? What antibiotic will you give for treatment of a positive endotracheal culture due to Pseudomonas aeruginosa? Time is up. The right answer is none. So thank you so much for participating actively. Let us see the winners at the end of role play by Dr. Sri Krishna sir. Dr. Nagamani ma'am to introduce Dr. Sri Krishna sir.
Yeah.
And meanwhile I'll play the role play.
Yeah. I welcome Dr. Sri Krishna to this continuing webinar. Is he there, Sri Krishna?
Yes, already here, madam.
Yeah. Very good afternoon. Dr. Sri Krishna is the professor of pediatrics from Apollo Institute of Medical Sciences, Hyderabad. And he served as a PATS secretary in 2018, and he's the instructor of the PALS and also NRC programs. And he's very actively involved in cultural activities, and he's a singer and he's a teacher, he's everything. He's a multi-talented, rather, I would say. Over to you, Sri Krishna.
Thank you, madam, for this introduction.
All-rounder, madam, all-rounder.
No. First of all, I'm very much thankful to President PATS, Dr. Surendra sir, and Secretary Pawan Kumar for giving this opportunity. And as Tanu Singhal madam showed very good case presentations where you may miss the right antibiotics so that patient may worsen. On other hand, the problem in many OPs is overusage of antibiotics.
Yeah.
So like what she told is under usage of antibiotics, right? If you don't choose the right antibiotic and if you don't give for appropriate duration and doses, the patient will worsen. But on the other hand, when you are over treating the patient with unnecessary antibiotic therapy, that also caused the problem. So to show that, one simple example is the diarrhea and its antibiotics. We keep listening, we keep studying right from the PG days, that the diarrhea doesn't require antibiotics. So I have just a 10 minutes how to counsel the patients when they are asking for, insisting for antibiotics. And especially we give antibiotics for multiple reasons, even in simple diarrhea also. Sometimes it's a pressure from the patients, sometimes it's our own fear that patient may get worsen. So how to handle these issues? So I have just 10 minutes of video presentation, where the actual role play is not by me. I am a doctor here and there also. Our one more PG has played as a mother. 10 minutes of video followed by 5 minutes of small presentation by me. So Dr. Pawan, please play that.
నమస్తే డాక్టర్ గారు.
నమస్తే అమ్మా.
Can you hear, sir?
ఎలా వచ్చారు?
మా పాపకి నీళ్ళ విరోచనాలు అవుతున్నాయి డాక్టర్ గారు. 2 రోజుల నుంచి ఏం సరిగ్గా తినట్లేదు. చాలా భయంగా ఉంది డాక్టర్ గారు.
అవునా? పాప వయసు ఎంతమ్మా?
9 నెలలు డాక్టర్ గారు.
ఎన్ని రోజుల నుంచి ఇలా బాధపడుతుంది?
2 రోజుల నుంచి ఇట్లా బాధపడుతుంది డాక్టర్ గారు. ఏం తినట్లేదు.
యూరిన్ పోసి ఎంతసేపు అయిందమ్మా? మూత్రం పోసి
పొద్దున పోయింది డాక్టర్ గారు, మళ్ళీ వెళ్ళలేదు.
అంటే ఎంత నీళ్ళుగా అవుతున్నాయా విరేచనాలు, లేకపోతే ఏమైనా జిగురులాగా అట్లా ఏమైనా రక్తంలా పడుతుందా?
లేదు డాక్టర్ గారు, ఓన్లీ నీళ్ళలాగా అవుతున్నాయి.
అవునా? సో పాపకి డయేరియా అనే వ్యాధి వచ్చిందమ్మా. నీళ్ళ విరేచనాలు అంటాం తెలుగులో దీన్ని.
ఓకే డాక్టర్ గారు. డయేరియా అంటే ఏంటి డాక్టర్ గారు?
డయేరియా అంటే కడుపులో ఇన్ఫెక్షన్ అయ్యి, ఆ ఇన్ఫెక్షన్ వలన కడుపులో ఉండే నీరంతా కూడాను మోషన్ ద్వారా వెళ్ళిపోతూ ఉంటుంది. దాన్నే నీళ్ళ విరేచనాలు లేదా డయేరియా అంటాం.
డయేరియా ఎందుకు వచ్చింది డాక్టర్ గారు? ఇది ఎలా వ్యాప్తి చెందుతుంది?
డయేరియా అనే వ్యాధి మన చేతుల విషయంలో కానీ, తాగే నీళ్ళ విషయంలో కానీ, లేదా తినే ఆహారంలో కానీ ఏమైనా పరిశుభ్రత లోపిస్తే వస్తుందమ్మా. కాబట్టి ఈ విషయంలో మనం చాలా జాగ్రత్తగా ఉండాలి. ముఖ్యంగా చిన్నపిల్లలకి వల్ల ఈ పరిశుభ్రత లోపించడం వల్ల రకరకాల బ్యాక్టీరియాలు, వైరస్లు అనేవి శరీరంలోకి వస్తాయి. ఈ నోటి ద్వారా వచ్చిన వైరస్లు, బ్యాక్టీరియాల వల్ల కడుపులో ఇన్ఫెక్షన్ పెరిగి ఇట్లా నీళ్ళ విరేచనాలు అనేది వస్తుంది.
అవునా అండి, నేను చాలా పరిశుభ్రత పాటిస్తానండి. ఇప్పుడు అసలే కరోనా కాబట్టి అసలు చేతులు కడుక్కోకుండా ఏది ముట్టుకోవట్లేదు. అయినా కూడా ఇంకా ఎలా కంట్రోల్ చేయాలి డాక్టర్ గారు?
మీరు జాగ్రత్తలు పాటించినానమ్మా. ఈ వయసులో ఉండే ప్రాబ్లమే అది. మీరు ఎంత శుభ్రతగా పాటించినా కూడాను ఈ చిన్నపిల్లలు ఒక చోట కుదురుగా ఉండరు. ముఖ్యంగా 5వ నెల 6వ నెల దాటిన పిల్లలు కింద పాకుతూనే ఉంటారు. మీరు ఏ వస్తువు ఇచ్చినా కూడా వెంటనే నోట్లో పెట్టుకుందామని చూస్తూ ఉంటారు. ప్రతిదీ, అది ఆట వస్తువు కానీ మామూలు వస్తువు కానీ, ప్రతిదీ నోట్లో పెట్టుకునే ఈ అలవాటు వల్ల వాళ్ళకి ఇన్ఫెక్షన్ వచ్చే అవకాశం చాలా ఎక్కువగా ఉంటుంది.
ఓకే డాక్టర్ గారు. సరే డాక్టర్ గారు, కానీ ఇప్పటికే 2 రోజులు అయిపోయింది. పాప ఏం తినట్లేదు. ఇంట్లో అందరికీ చాలా భయంగా ఉంది. తొందరగా తగ్గించడానికి చూడండి డాక్టర్ గారు.
ఇది వైరల్ డయేరియాలా ఉందమ్మా. ఈ పర్టికులర్గా ఈ ఏజ్ గ్రూప్లో పిల్లలకి ఇది వైరల్ డయేరియా చాలా కామను. ఇది మనం మందులు ఇచ్చినా ఇవ్వకపోయినా కనీసం 5 రోజుల నుంచి 7 రోజుల దాకా పట్టేలాగా ఉన్నదమ్మా.
5 రోజులు 7 రోజులు అంటే పాప ఏమీ తినట్లేదు కదా డాక్టర్ గారు. చిన్నపిల్ల కదా, ఎట్లా తట్టుకుంటుంది? యాంటీబయాటిక్స్ లాంటివి ఏమైనా పెట్టండి డాక్టర్ గారు.
జనరల్గా అందరూ చేసే పొరపాటే అదేనమ్మా. ఇలా టెన్షన్ వచ్చి చాలామంది రకరకాల యాంటీబయాటిక్స్ వాడుతూ ఉంటారు. అది తగ్గుతుందేమో అని, ఇది తగ్గుతుందేమో అది అని చెప్పేసి ఈ యాంటీబయాటిక్స్ వాడడం వల్ల ఒక్కొక్కసారి అసలు మామూలుగా ఈ వైరల్ ఇన్ఫెక్షన్ తగ్గకపోగా ఒక్కోసారి ఈ యాంటీబయాటిక్ వల్ల ఎక్కువ రోజులు మోషన్స్ అయ్యే అవకాశం కూడా చాలా ఉంటుందమ్మా.
అవునా డాక్టర్ గారు? 6 రోజులంటే ఏం మందులు ఇద్దాం డాక్టర్ గారు పాపకి?
బేసిక్గా డయేరియాలో ముఖ్యమైన ప్రాబ్లము డీహైడ్రేషన్ అమ్మా. ఈ డయేరియా కన్నా మనం భయపడాల్సింది మెయిన్గా డీహైడ్రేషన్కి. ఈ డీహైడ్రేషన్ వల్ల ఒంట్లో నీరంతా వెళ్ళిపోయి యూరిన్ తగ్గిపోయి పిల్లలకి కాళ్ళు చేతులు చల్లబడిపోవడము సీరియస్ కావడము ఉంటుంది. కాబట్టి డీహైడ్రేషన్ అనేది రాకుండా చూసుకోవడం అనేది ముఖ్యంగా ఈ వారం రోజులు మనం చేయాల్సిన పని అమ్మా.
అయితే దీనికోసం ఏం చేయాలి డాక్టర్ గారు? మా ఇంట్లో ఒక టెట్రా ప్యాక్ తీసుకొచ్చి ఫ్రెండ్ వాళ్ళ పాపకు కూడా ఇట్లనే అయితే దాంతో తగ్గింది అని అన్నారు, కానీ మీరు చెప్పలేదని నేను అది ఇంకా ఇవ్వలేదు డాక్టర్ గారు. ఎలా తగ్గిద్దాం దీన్ని?
మంచి పని చేశారమ్మా. డీహైడ్రేషన్లో మనం ఇవ్వాల్సినవి ఓఆర్ఎస్ వాటర్ అమ్మా. ఇప్పుడు ఈ ఓఆర్ఎస్ అనేది మనకి విడిగా అన్ని మెడికల్ షాపుల్లోనూ తర్వాత గవర్నమెంట్ సెక్టర్లోనూ దొరుకుతున్నది. ఇవి 1 లీటర్ ప్యాకెట్లు కలిపే పొడి ఒకటిను, అలాగే జస్ట్ పావు లీటర్ అంటే 250 mlలో కలిపే పొడిగాను విడిగాను దొరుకుతున్నాయమ్మా. మనము ఆ 1 లీటర్ ప్యాకెట్స్ అయితే గవర్నమెంట్లో ఫ్రీగాను దొరుకుతున్నాయి. ఈ ప్యాకెట్స్ తీసుకొచ్చి 1 లీటర్ క్లీన్ వాటర్లో కలిపేసి అది పదే పదే తాగిస్తున్నట్టయితే చాలా వరకు ఈ డీహైడ్రేషన్ రాకుండా ఆపుకోవచ్చు. అలాగే వీళ్ళది మనం ప్రైవేట్గా అయితే చిన్న మెడికల్ షాపుల్లో 250 mlలో కలిపే ప్యాకెట్స్ కూడా చిన్నవి దొరుకుతున్నాయి. ఒక గ్లాస్ ఆర్డినరీ సైజ్ గ్లాసు 250 ml ఉంటుంది, అందులో కలిపి ఈ నీళ్లు పదే పదే తాగిస్తున్నట్లయితే ఆ డీహైడ్రేషన్ అనేది రాకుండా ఆపుకోవచ్చు. ముఖ్యంగా ఏంటంటే డయేరియాలో డీహైడ్రేషన్ రాకుండా ఆపుకోవడమే మెయిన్ ట్రీట్మెంట్. అంతేగాని ఇది తగ్గించాలని ఆపేయాలని రకరకాల మందులు కానీ లేకపోతే ఈ యాంటీబయాటిక్స్ లాంటివి కానీ అస్సలు వాడకూడదమ్మా.
ఓకే డాక్టర్ గారు. ఒక ఓఆర్ఎస్ ఇస్తే సరిపోతుందా డాక్టర్ గారు? నిజంగా తగ్గుతుందా దాంతో?
చూడమ్మా, ఓఆర్ఎస్ వల్ల మోషన్స్ తగ్గవు. మోషన్స్ వాటంతట అవే తగ్గుతాయి. ఎందుకంటే మనకి పేగుల్లో దాని రికవరీ శక్తి అనేది ఎప్పుడూ ఉంటుంది. ఈ 5-6 రోజుల్లో ఈ మోషన్ ద్వారా వైరస్లు అవన్నీ కూడా వెళ్ళిపోయి మళ్ళీ నార్మల్సీకి వస్తుంది. కాకపోతే ఈ పీరియడ్ ఈ ఓఆర్ఎస్ అనేదాన్ని పదే పదే ఇస్తుండడం వల్ల వాళ్ళు చాలా బెటర్గా ఉంటారు. అంటే మనం డీహైడ్రేషన్ అనేది రాకుండా ఓఆర్ఎస్ ఇస్తే సరిపోతుంది ఈ డయేరియా విషయంలో. అంతే తప్ప వేరే మందులు వాడాల్సిన అవసరం అస్సలు ఉండదు. ఈ మధ్య కొంచెం జింక్ సొల్యూషన్ కూడా ఇస్తున్నారు గవర్నమెంట్ వాళ్ళు రికమెండ్ చేస్తున్నారు. జింక్ కూడా కొంతమంది అంటే 5 ఏళ్లలో పిల్లలకి జింక్ సొల్యూషన్ కూడా మనం ఇవ్వవచ్చు. ఈ ఓఆర్ఎస్ అనేది మనం ఎలా తాగిస్తున్నాము అనేది ముఖ్యంగా దీన్ని సరిగ్గా కలపాలి. అందులో ప్యాకెట్ మీద ఇచ్చినట్టుగా సరిగ్గా కలిపి ఆ నీళ్ళని పదే పదే తాగిస్తూ ఉండాలి. మరి ఎంత తాగించాలని డౌట్ వస్తుందమ్మా. అది ఏంటంటే ఈ పిల్లవాడు ఎంత అప్రాక్సిమేట్గా చెప్పాలంటే వాళ్ళు ఎంత మోషన్ వెళ్తే దాదాపు అన్ని నీళ్లు మనము ఓఆర్ఎస్ ద్వారా చెంచాతో మెల్లిమెల్లిగా తాగిస్తూ ఉండాలి. దాని ద్వారా వాళ్ళకి డీహైడ్రేషన్ రాదు. అలాగే డీహైడ్రేషన్ లేదని మనకి ఎలా తెలుస్తుంది అంటే వాళ్ళ యూరిన్ అవుట్పుట్ వల్ల, అంటే గంటలో ఒక ప్రతి 1-2 సార్లు యూరిన్ పోస్తున్నట్టయితే లేదా 24 అవర్స్లో ఒక కనీసం 6 టైమ్స్ యూరిన్ పోస్తున్నట్టయితే వాళ్ళకి డీహైడ్రేషన్ లేదని తెలుస్తుంది. ఈవెన్ ఆ యూరిన్ కూడా క్లియర్గా వాటర్ లాగా ఉండాలి. అప్పుడు వాళ్ళ సరిపడా వాటర్ శరీరంలో ఉంది, వాళ్ళ డీహైడ్రేషన్ లేదు అని మనకు తెలుస్తుంది. అలాగే డీహైడ్రేషన్ లేకుండా ఉంటే మోషన్స్ అవుతున్నా సరే పిల్లలు యాక్టివ్గా ఆడుకుంటూనే ఉంటారు. సో వీటన్నిటి వల్ల మనకి ఇది డీహైడ్రేషన్ని మనం నివారించాము అని మనకి ధైర్యంగా మనం ఉండవచ్చు.
ఓకే డాక్టర్ గారు. ఓఆర్ఎస్ కాకుండా ఇంకేం తాగిపించవచ్చు డాక్టర్ గారు?
ఓఆర్ఎస్ కాకుండా వేరే ద్రవాలంటే అన్నిట్లోకి బెస్ట్ ఓఆర్ఎస్ఏ. ఈ ఓఆర్ఎస్తో పాటు కొంతమంది పిల్లలకి అది ఇష్టంగా ఉండకపోవచ్చు, కానీ నిజంగా సరిగ్గా కలిపినట్టయితే చాలామంది పిల్లలు మామూలుగా ఈ ఓఆర్ఎస్ తీసుకుంటారు. ముఖ్యంగా డీహైడ్రేషన్లో ఉండే పిల్లలు ఇంకా ఎక్కువ తీసుకుంటారు దీన్ని. అండ్ రెండవది ఏంటంటే ఈ ఓఆర్ఎస్ఏ కాకుండా ఒకవేళ మనం ప్లెయిన్ వాటర్ కూడా మధ్య మధ్యలో ఇవ్వచ్చు. అంటే మామూలు శుభ్రమైన నీళ్ళు రోజు ఇచ్చేవి పదే పదే ఉండొచ్చు. పల్చటి మజ్జిగ కొంచెం ఉప్పు వేసి కానీ, అలాగే అన్నం గంజిలో కాస్త ఉప్పు వేసి కానీ అది కూడా చేసి పదే పదే ఇస్తూ ఉండవచ్చు. అంటే రకరకాలుగా ఇస్తూ ఉండడం వల్ల లిక్విడ్స్ వాళ్ళు కూడా ఇష్టంగా తీసుకుంటూ ఉంటారు. దాని ద్వారా వాళ్ళకి డీహైడ్రేషన్ రాకుండా ఆగుతుంది.
ఓకే డాక్టర్ గారు. సరే డాక్టర్ గారు, ఇంకా ఏమేమి తినిపించాలి డాక్టర్ గారు? ఏమైనా
ప్రతి ప్రత్యేకించినప్పుడు నిజానికి ఇది తినిపించాలి తినిపించకూడదు అని లేదు, కానీ ఈ వయసు పిల్లలకి ప్రతిరోజు మనం ఏమేమి పెడుతున్నామో చూసుకుని, అంటే అన్నం లాంటిది పెడుతున్నట్టయితే అన్నం గుజ్జులాగా చేయడము, కొంచెం పల్చగా చేసి పెట్టవచ్చును, లేదా కాస్త అరటిపండు లాంటిది కూడా కాస్త మెత్తగా చేసి పెట్టవచ్చు. అంటే ప్రతిరోజు మనం ఏం పెడుతున్నామో అదే పెట్టవచ్చు, కాదు కొంచెం కారాలు లాంటివి లేకుండా చూసి పెడితే సరిపోతుంది. ప్రత్యేకించి వేరే పథ్యం అంటూ దీనికి ఏమీ ఉండదు. అలాగే జ్యూసెస్ విషయంలోకి వస్తే మాత్రం నేను ఇంతకుముందే చెప్పినట్టు ఓఆర్ఎస్ ముఖ్యంగా తాగించాలి. ఓఆర్ఎస్తో పాటు ప్లెయిన్ వాటర్ కూడా మధ్యలో ఇస్తూ ఉండవచ్చు. అలా కాకుండా కొంతమంది ఈ మీరంటూ టెట్రా ప్యాక్లో అట్లా ఇవ్వడంలో కానీ, లేదా ఈ ఫ్రూట్ జ్యూసెస్ ఇవ్వడం కానీ, కొంతమంది తాగట్లేదని చెప్పేసి కూల్ డ్రింక్స్ ఇవ్వడము, ఆ తీపి ఎక్కువగా ఉండి ఇవ్వడం చేస్తూ ఉంటారు. ఇవి చేయడం వల్ల డయేరియా ఇంకా సీరియస్ అవుతుంది. దానివల్ల వాళ్ళ డిహైడ్రేషన్ ఎక్కువ అయ్యే అవకాశం ఉంటుంది. కాబట్టి ఇవి ఇవ్వకుండా ప్లెయిన్ వాటర్ ఇవ్వవచ్చును, లేదా ఈ ఓఆర్ఎస్ వాటర్ ఇవ్వడం ఇంకా మంచిది.
ఓఆర్ఎస్ బట్టి జాగ్రత్తగా చూసుకుంటాను డాక్టర్ గారు. ఇంతవి డయేరియా నివారణ ఎలాగో నాకు చాలా బాగా అర్థమైంది. చాలా థ్యాంక్స్ డాక్టర్ గారు. మంచిదమ్మా,
అందరూ మీలాగే వివరంగా డాక్టర్ దగ్గర తెలుసుకొని డయేరియాకి మంచి మందు, అసలైన మందు కేవలం ఓఆర్ఎస్ సొల్యూషన్ మాత్రమే అని దాన్ని పదే పదే ఇస్తుండడం వల్ల డిహైడ్రేషన్ రాకుండా మన పిల్లల్ని మనం కాపాడుకోవచ్చు. ఈ ఓఆర్ఎస్ తప్ప మిగతా మందులన్నీ, అంటే మా మోషన్స్ తగ్గడానికని మనం మెడికల్ షాపులో వెళ్ళి తీసుకోవడం కానీ, లేదా ఏమైనా యాంటీబయాటిక్స్ ఇవ్వండి అని చెప్పేసి వాళ్ళు అక్కడ అడిగి తీసుకొని వచ్చి వేయడం కానీ, ఇలాంటివి చేయడం వల్ల అనవసరంగా మనం పిల్లని ఇంకాస్త ఇబ్బంది పెట్టినట్టే అవుతుంది. కాబట్టి చాలా సింపుల్ డిసీజ్ని స్మూత్ అయిన ట్రీట్మెంట్ తోటి తగ్గించుకోవడం అనేది అందరూ తెలుసుకోవాల్సిన విషయం.
Thank you so much, sir. That shows your patience in counseling the patient. I think patient is very much satisfied.
I don't know how many
looks very much satisfied. Yeah.
This may be boring. I thought this may be boring for everyone because they are all practicing well about this. But I try to concise, but at least minimum matter should be included. I still
right, sir.
Just a small presentation. Just for 5-6 slides only. Pawan?
Yes, sir. Yes, sir. Yeah.
You have to allow.
I'll make you co-host, sir. 1 second. You are already co-host, sir. Just see 1 second.
No. Host design.
Are you able to? 1 second, sir. Yes, sir. 1 second. I'm just doing it.
So Dr. Ishwachari raised his hand, sir.
No,
Yeah.
madam. I want to tell something. You must encourage in between breast milk feeds below 1 year children. Along with that, that did not highlight.
Yes, sir.
You
Yes,
are
sir.
not
True,
highlighted
sir.
it because you
True, sir.
mother.
Actually, I want to concise the treatment, and the topic is about against the antibiotics usage.
No, there is no. This is not antibiotic.
But what you
must encourage
what
breast
you are
milk.
telling, that's true,
In
sir.
between, mother should. So mother will go on giving only ORS instead of breast milk.
That's true, sir. That's true.
So you must
Accepted,
encourage
sir.
in between. In between
Yes,
two,
sir, yes.
one breast milk must be given.
Come with a revised one with
Okay.
adding zinc also.
Yeah, zinc I told me, madam.
Zinc already
I
told, madam. Zinc told, but she is not mentioned breast milk.
Yes,
Feeding,
yes,
feeding.
yes. That's true. Yeah? So it's a very small presentation, though it's known for all. Just hello, is it clear?
Yes, sir. Yes, sir. It is clear, sir. You can put on full screen and start, sir.
Okay. Thank you, dear President and Secretary of PATS, for giving this opportunity. It's a though the topic is about the antibiotic usage, the proper usage already told by Dr. Tanu Singhal. Here, what is irrational in the treatment and the simple disease where we are unnecessarily complicating the disease, because the disease is simple, the treatment also simple, but we are complicating by giving multiple types of medicines in the area, like one is antibiotics and one is antibiotics and again including anaerobic combinations, and even the anti-diarrheals like loperamide and other things. So just about that. So just we'll have a review about it. What are the indications of antibiotic in diarrhea? This everyone knows, right? From undergraduate timings, we are reading again and again, like we know that the blood and mucus stools for enteroinvasive bacteria seen, and the child less than 3 months, because there is a risk of gram-negative sepsis in them, and cholera only to prevent community spread, parental diarrhea depending upon that infection, and immunocompromised host. These are the only indications where you can think about the antibiotic in watery stools. Actually speaking, in the day-to-day practice, these above 5 diseases constitute not even 5%, but antibiotics are seen in almost 90% of prescriptions of diarrhea. That is the most sad thing here. So what are the sources of antibiotic? Source of antibiotic to the child, from where he is getting these antibiotics? So you can see that many ways he is getting it. Many times the parents see the old prescriptions and use that. Second is that they give that the siblings prescriptions and the neighbors advice. Neighbors are well known to give this combination of ornidazole and ofloxacin, and pharmacist advise also that the parents go and ask for medicine for diarrhea. First, you will give these combinations only, and many paramedicals. If somebody is working has a experience of a lab job, so he is also become a doctor in advising the antibiotics. And the so-called semi-medical people like RMPs, or even the medical peoples like nurses and even non-allopathic doctors. So many people are there to dump antibiotics in the children for small diseases. But above all, I can say that it is a allopathic doctor's advice, because I've seen many practitioners, once they start using the antibiotics in the beginning, then the surrounding, generally many of our allopathic doctors are surrounded by RMPs and other non-medical or non-allopathic doctors. They follow this doctor advice. That's how the irrational use of antibiotics has become a routine in the case of diarrhea. So here, all of us know that watery stools are mostly viral, and even the viral diarrhea will take its own time for 5 to 7 days. And we also know that the antibiotics will not work in viral diarrhea, and also know that even the bacterial diarrhea will not require antibiotics if it is watery, because it is secretory diarrhea. Then why are we writing antibiotics for watery stools? I don't see any particular scientific basis behind it, except the emotional component of the practitioners. So I'm sorry to say this is a little bit harsh regarding these matters, because in spite of studying in the PG days and later, in spite of attending so many CMEs or not attending also, there is not much change in prescription of many doctors. So I just observed some of the doctors. I spoke to them, and even I just observed why they are writing it. So I can say these are the crazy reasons why allopathic doctors are writing antibiotics for diarrhea. Here, some of the doctors are having ignorance and lack of full knowledge about the disease pathogenesis itself, that the diarrhea, watery diarrhea will be there for 5 to 7 days. We can say this as a ajnana. And some of the doctors say that they have a casual attitude both towards the patient, even about the disease also. Okay, what is there in diarrhea? We can do something. We can give anything in this. And they have a casual attitude even with the antibiotic. Okay, any antibiotic will go. Something we should give. So with attitude of for whatever worth it is the attitude. Because I asked one doctor, he himself told that, okay, we'll start antibiotic for whatever worth it is. He's very famous practitioner also. So I can say that these are just a tamoguna only. And over anxiety of missing the patients. This is a funny reason. Even the youngster who just started the practice, he feels that though he knows that the antibiotic is not needed, initially he'll think that, okay, let me start the antibiotic till I get a very good practice. So, but after 10 years, he is having very good practice. Still, he is not able to live it, and with the intention that I may miss the practice. So I may lose the patient. Thus, this continues, this anxiety is continuing in the practitioners. But for how many days? Even the doctor at 60 or 70 years also writing this just out of anxiety only. And some of them have a defensive method. That they practice with fear. Always they have a fear that maybe if some antibiotic, okay, we are giving other medicines, ORS, why not we add this also? So something like addition, when you are eating something, you take some achar. Like achar, they are having, adding this antibiotic also. So sometimes they have over enthusiasm that if something, they have a zeal to write something which others are not writing. So this we can call ati utsaham, atyutsaham. So some people have a euphoria that they always feel that whatever I write, I am always correct. I can say this as ahankar. I am so very sorry to use these terminologies, but these are my observations. Why they are, in spite of attending so many CMEs, in spite of passing out with good marks in MD and the MBBS, why they are continuing these wrong practices? Then finally, I felt that these are non-scientific and more emotional components. So, and sometimes there is a fear of competition from others. If I don't write antibiotic, this patient will go to some other place and he will get the antibiotic. So this we can say that some amount of matsarya, that he may get more patient and I may lose it. So that means we are not writing the antibiotics out of strong scientific basis, but we are writing more of emotional mistakes from our side. And much worse, worst is combination of antibiotics with imidazole groups like metronidazole, ornidazole, already written in chart box also I have seen that when you are writing both, it simply shows that we don't have proper knowledge about bacteria, virus, anaerobic or amoebic infections. That clearly, if somebody is writing this, means we don't have an idea about all these infections. And we believe, these doctors believe in throwing multiple stones in the darkness instead of trying to understand properly. And important is they are not confident of their own diagnosis and treatments. And they don't even bother that these combinations have multiple problems in future. But one thing, who are we to spoil child's healthy gut flora? Because we should remember that the children are suffering with our own ignorance, that is ajnana. The solution is just go back to basic books and improve your knowledge. What will happen if we don't give, if we give unnecessary antibiotics? As I already told that if you don't give antibiotics, what Dr. Tanu Singhal told, if you don't give proper antibiotics, we may lose the child immediately or very soon. But if you don't give, if you give irrationally, we have long-term bad effects because it is going to change the gut flora, these antibiotics. And we know that the gut flora is very, very important for our proper digestion and absorption and for priming of our immune system of the body. And they are very important for prevention of allergic, autoimmune and malignant diseases. And they are important for the production of B12 and K vitamin. And we can say that GI tract is known as a second brain in multiple ways. GI disturbances due to disturbed gut flora can have a long-lasting effect even on CNS. So in this case, who are we to spoil the gut flora of the child by our irrational antibiotics when he is coming to us with high hope with the cure of the disease? So this is a high time that we should realize that it's my sincere request and advice to my juniors also. We should awake before we get pre-antibiotic era again, and before we get a pandemic of antibiotic resistant bacterial infections. We are seeing one pandemic now. Tomorrow we may get multiple pandemics with multiple antibiotic resistant bacterial infections. And before we get multiple diseases of next generation, both infectious and non-infectious, because irrational antibiotics can cause even non-infectious disease also. They can increase that. And before the community blame our medical fraternity for throwing them into the medical disasters. So this is my sincere request. Write antibiotic before writing the antibiotic. think thrice before you ink. So don't make it as a routine spinal reflex action. Thank you very much. I am sorry if I am a little bit harsh in making this. Thank you very much.
Sir, thank you so much, sir, for that wonderful short, but very message oriented. It will definitely change the antibiotic practices of the practitioners. So now the quiz winners time. I think I'm just putting it in the chat box. But hello, sir. These are the Rapstar prize winners, sir. Dr. Mahin, Dr. Chandramouli, sir, Dr. Shweta, Dr. Prasanna, and Dr. S. Srikanth. So was I muted before?
Yeah, Pavan.
So we are going to send the gift. Yeah, over to you, Dr. Surendranath, sir, for concluding remarks before going to vote of thanks.
Nagmani madam. She is the chairperson.
Madam, can you unmute yourself? Yes. Now, before handing over to madam,
Yeah, we had wonderful session with interactions and all, and especially I congratulate Sri Krishna.
Madam, please unmute, ma'am. Surendranath sir, అందరిని మ్యూట్ చేసినట్టున్నారు సడన్ గా.
Yeah. Thank you all the
Yes,
EB
ma'am.
members.
Go ahead, ma'am. Yeah.
Thank you for all the EB members and the president, sir, and also Secretary Pat, Pawan, especially Tanu madam, in spite of her busy schedule. I thank you one and all.
Thank you, madam. Dr. Srinivas, kindly propose vote of thanks. Dr. Srinivas, our treasurer.
Yes, sir. Yes, sir. Yes, sir. Good evening, everybody. I thank. Yes, sir. I'm audible, sir. I'm audible.
Yes, you are audible and visible.
Yes, sir. I thank the today's speaker, Dr. Tanu Singhal, madam, today's speaker, for her excellent lecture on the racial antibiotic use in the PICU and ICU. Madam gave the lecture excellently and new insights into the racial use of antibiotics. I thank Dr. Nagamani madam, that's EV, Central EV member, and Central Vice President IAP, and also the Central EV members, Dr. Ishwant Rao, Dr. Narahari sir, and Dr. Narayan Reddy sir, and also the past President, Dr. Himabindu madam, and Dr. Lakshman Kumar sir. And I thank the President, Secretary PATS, for conducting today's excellent lecture. I thank Dr. C. Krishna for his role play in the racial use of antibiotics in the diarrhea. He has given a very good insight and also role play. And the quiz also was conducted in a very excellent manner on the relevant topic of madam's lecture today. I thank all the participants of today's webinar of PATS. I thank each one and all. Thank you, one and all.
Thank you. One, we can leave now.
Yes, sir. Yes, now the session is over. It was very successful. Almost all 80 participants have joined. So it's very successful one. Thank you so much, one and all.
Thank you everybody. Thank you one and all.
Next RAP Sunday will be second Sunday in the May.
Okay. Thank you.
Himabindu madam is there.
Ma'am, you want to say anything?
Hearty congratulations to see you, very smart president and the secretary, dynamic secretary, doing very good. PATS, I'm very happy that many new things, innovations are coming from our state, IAP Telangana, prizes and keeping everybody on, task. So very nice. I really enjoyed it, and a great going, PATS.
Congratulations, Surendranath, Pawan. May I request
Oh,
you to
Mr.
please
RSV is there.
consider
Last minute entry.
Pavan and Surendra sir, for next month, please consider Mr. Vikram, who is a IT software engineer at Microsoft, who wants to talk about his addiction to use of my antibiotics.
Addiction to
Okay.
use.
Okay,
Yeah,
we will keep in the role play time.
Yeah,
We will
I am
invite.
that Vikram.
Role play.
Yeah, please. I'll come in my Mercedes and then ask for an antibiotic.
Okay. Okay. Okay.
You are going to speak, huh?
No, sir. I am Vikram, sir.
Sri
I
Krishna
come in my
Vachesaru.
Mercedes.
అవునా
I
మేడం, థ్యాంక్ యూ
come in
మేడం.
my Mercedes and ask for antibiotics, sir. మీరే డాక్టర్ ని డిసైడ్ చేయండి. నేను మాత్రం విక్రమ్.
Acha, okay.
Mercedes is the Mercedes real or virtual Mercedes?
బేస్మెంట్ కి వెళ్తే బోల్డ్ ఉంటాయి మా దగ్గర. రోల్ ప్లే అక్కడి నుంచి మొదలెట్టుకుని వస్తా, దానికే ఉంది.
కరెక్టే.
బాగా మాట్లాడే కాదు, బాగా మాట్లాడే డాక్టర్ కార్ ఇచ్చేస్తానంటే నేనే మాట్లాడతా.
పవన్ రేపు ప్రోగ్రామ్ ఉంది, ఇక్కడ లోకల్ ఇన్వైట్ చేయట్లేదా?
యా మ్యామ్, లోకల్ ఇన్విటేషన్ ఇప్పుడు ఈ ప్రోగ్రామ్ అయినాక ఐ విల్ సెండ్ మ్యామ్ ఎవ్రీబడి. యా
డాక్టర్ సురేంద్రనాథ్ knows na?
Yes, yes ma'am.
Tomorrow's program.
Tomorrow. Yeah, yes ma'am. Delhi IAP Delhi Mission Lakshya, IAP Delhi Mission Lakshya program.
Okay, we are the tail enders, no problem.
No, but you are the host. You are the main. Delhi and IAP Telangana.
First starting లో కూడా మీరు మాట్లాడాలి కదా.
Okay.
అవును కదా, ఏం ప్రెసిడెంట్ గారు.
Okay. Okay. See you tomorrow.
Okay. Bye bye.
అండ్ జాయిన్ నెక్స్ట్ మంత్. నేను ఇప్పటి నుంచే ప్రిపేర్ అయి ఉంటాను. క్యారెక్టర్ లో బాగా దిగిపోతా పవన్. మంచి డాక్టర్.
Dr. Tanu, thank you so much.
Go ahead,
Dr. Tanu Singhal. I hope nice to see you. Thank you for coming over.
RSV ఇప్పుడే డాక్టర్ చూస్ చేసుకో.
ఎవరైనా పర్లేదు సార్.
నువ్వు విక్రమ్ కాదు, నువ్వు విక్రమ్ అయితే మరి ఎవరు బెహతాలో చూడు.
ఎవరో ఒకరు తాండి, నేను మాత్రం అస్సలు వదల.
అయితే సరే చూద్దాం.
ల్యాన్సెట్ తో వస్తా, వచ్చేది ల్యాన్సెట్ పట్టుకుని వస్తా.
సురేందర్ సార్ కరెక్ట్ పర్సన్, అప్రాప్రియేట్ పర్సన్ పెట్టండి ఈయనకి.
రవికుమార్ సార్ పెడదాం వైస్ ప్రెసిడెంట్.
సెంట్రల్ వైస్ ప్రెసిడెంట్. వీళ్ళు గట్టిగా మాట్లాడరు సార్. ఇట్స్ నాట్ యాజ్ ఇఫ్ దే స్పీక్ లౌడ్. ల్యాన్సెట్ మాట్లాడతారు అంతే.
తెలుసు ఆర్టికల్స్ తెచ్చి మాట్లాడతారు, తెలుసు నాకు.
సో దాని బేసిస్ మీదే మాట్లాడతారు. సో నేను క్యారెక్టర్ లోకి బాగా ప్రిపేర్ అయ్యి దిగిపోయి రెడీగా ఉంటా. మీరు నాకు తగ్గ డాక్టర్ ని తీసుకున్నాడు.
ఓకే, నాగమణి మేడం, థ్యాంక్ యూ వెరీ మచ్. చాలా రోజులైంది మిమ్మల్ని చూసి.
Nice to see you, Dr. Nagamani, Dr. Srinivas, all of you.
Ishwarachari sir, thank you for giving that nice input, sir. Ishwarachari sir.
Sir.
Sir, బాగున్నారా Ishwarya Sari sir?
We are now 73, dragging and pulling on our because of you only. Because our CM is regular CM is though for the last 2 years. For the last 2 years homebound.
సార్ మీరందరినీ చూస్తుంటే మాకు ధైర్యంగా ఉంటుంది సార్. పెద్ద దిక్కులు మీరే మాకు.
ఏం చేస్తారు చెప్పండి, మీరంతా మా
సీనియర్ పీడియాట్రిషియన్ కదా సార్ మీరు. ఇన్స్పిరేషన్ టు us.
ఓన్లీ సీనియర్ అంతే. పీడియాట్రిషియన్ ఇప్పుడు నో పీడియాట్రిషియన్, సీనియర్ సిటిజన్. యు కాల్ మీ యాజ్
మేము తప్పు చేస్తే మాకు చెప్పేవాళ్ళు ఎవరు సార్? మీరు కాక.
అదే ఓన్లీ సీనియర్ సిటిజన్. నౌ పీడియాట్రిషియన్ has gone. Role of pediatrician gone. Now we are become senior citizens. Thank you very much. Your lovely presentation, Sri Krishna. Though I enjoyed your at Bhaskara Medical College onwards, I am seeing you.
Yes sir.
You are my assistant at Bhaskara Medical College.
Yes sir. Thank you sir. Thank you very much.
Thank you. Very good. Thank you. Okay.
Thank you.
God bless you.
Thank you sir.
Thank you sir. Thank you. We can all leave now. Enjoy with the family. Enjoy Sunday. Happy Sunday.
Thank you.
Thank you. Bye.
Bye.